This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patient survive this podcast? It's up to you and the choices you make. Our episode today is called The Pill Paradox. Want to know what over-the-counter drug is lethal to pets? What important toxicology tool was plotted on a cocktail napkin? What's the medical use of a barbiturate coma? Then listen to find out. The next chart in your emergency department queue is a 16-year-old girl with a chief complaint of nausea and vomiting. The nursing note says, overdose, suicide attempt. A glance at the monitor as you enter the room shows the following vital signs. Heart rate 100 beats per minute, respiratory rate 18 breaths per minute, blood pressure 110/60, and oxygen saturation 100% on room air. The nurse holds a thermometer in the teen's mouth, and after a few seconds, it beeps. The temperature is 98.0 Fahrenheit or 36.6 Celsius. All the vital signs are completely normal. The nurse says a friend called 911 after receiving a text from the patient saying goodbye. She also texted she wanted to die and took an overdose. The patient is laying on the bed lethargic. She opens her eyes to voice but isn't speaking. Her affect is flat, meaning she's not reacting positively or negatively to anything happening around her. Other than the mental status and the affect, the rest of her physical exam is normal. She doesn't answer any questions, including your questions about what she overdosed on. Hoping for more information, you call the patient's family. They're en route to the hospital, extremely distraught, and have no idea what's happened. It's a mystery case. We have absolutely no information. What now? Well, this is actually a fairly common presentation in the emergency department and definitely a common call for toxicologists. Some patients with suicidal ideation don't want to tell you what they did. Some are so depressed, they're withdrawn and can barely speak, and others have an altered mental status from the overdose itself. So we're used to caring for these patients without knowing what happened. Fingers crossed, let's hope we figure out what she did before something bad happens to her. Question number 1. Which of the following tests do you want? A, an EKG, B, electrolytes, C, an acetaminophen level, that would be brand name Tylenol or paracetamol, D, an aspirin level, E, a urine drug screen, F, all of the above. The answer, if you answered F, all of the above, I'll give you full credit. I'd order an EKG, basic labs including electrolytes, and acetaminophen and aspirin levels. We often order liver function tests along with an acetaminophen level. Toxicologists understand the limitations of urine drug screens, and most of us don't order them routinely. However, this isn't the case, as I've mentioned before, with emergency medicine physicians, psychiatrists, hospitalists, and other consultants, so generally they are ordered. Why an EKG, did I hear you ask? Do we think this is a heart attack? No. The EKG screens for totally different things with an ingestion or overdose. We're screening for interval prolongation. QRS interval prolongation is caused by sodium channel blockade, including TCAs, an old category of antidepressants. More commonly these days, we're looking for QTC prolongation from potassium channel blockage. If present, it means there's a risk of a lethal arrhythmia, ventricular fibrillation. Listen to the Toxic T episode for more on that. If these findings are present, it can direct treatment, risk stratification, and help narrow down the exposure. You've ordered the test, so what next? That's question number 2. A, administer an antidote, B, wait and see what happens, or C, admit her to psychiatry. The answer is B. Watchful waiting on the cardiac monitor is the best approach. Currently, the patient is awake with normal vital signs, so no immediate intervention is needed. I'd monitor her clinical status while awaiting the lab results. Clearly, she needs psychiatric help, but she's not medically clear and medical treatment comes first. Once we've treated, or at least observed her for a period of time until she's out of danger, then after that we can consider psychiatric admission. The distraught parents arrive at the bedside. They say the patient seemed depressed over the past few weeks, was being bullied in school, but hadn't expressed suicidal thoughts. Yesterday evening, she complained of abdominal pain and vomited several times. This morning, she was a little better, though not well enough to go to school, and they were shocked to hear she'd overdosed when the friend's mom called about the texts. This is a good time to try to determine potential exposures. Of course, anyone can be exposed to anything, and we toxicologists love unusual and unexpected exposures. That said, common things are common, so it's useful to find out what medicines are in the house, in the garage, etc., to generate a list of potential possibilities. The patient doesn't take any medicines, according to the parents. Dad takes a blood pressure medicine, metoprolol, a beta blocker. So what do you think about this as an antihypertensive overdose? Well, currently her blood pressure and her heart rate are normal, so no. Now, of course, patients can overdose and be asymptomatic. They may have taken a small amount, and they might never develop symptoms. Also, it takes time for symptom onset. This is actually one of the most common questions emergency medicine physicians ask toxicologists: when to expect toxicity. If it's extended release pills, for example, onset could be delayed by 12 or 24 hours even. Continued observation for development of hypotension or a low heart rate is the best approach to determine if this is what she overdosed on. Mom takes glipizide for diabetes. The patient's blood sugar comes back normal, so again, less likely, though again, onset can be delayed. Per the parents, there are no other prescription drugs in the house. They do have over-the-counter drugs, including vitamins, ibuprofen, brand name Motrin, and acetaminophen or paracetamol, brand name Tylenol. Multivitamins rarely cause toxicity in adults. Ibuprofen also rarely causes toxicity. Massive overdose can cause nausea and vomiting with an elevated anion gap due to a metabolite called propionic acid. This is a potential for our patient, though an altered mental status is unlikely. Acetaminophen can definitely cause nausea and vomiting along with abdominal pain. I'd for sure keep this on my list of potential exposures. We sent an acetaminophen level and we're waiting the results. The parents deny supplement use. They live in an apartment, so there's no garage with toxic alcohols or pesticides. As far as they know, the patient doesn't use any drugs. Of course, the parents might not know about substance use issues, and drugs are often easy to obtain at school. Considering drugs of abuse, is this an opioid overdose? No, her breathing is fine and her pupils are normal. Benzodiazepines like Xanax can be misused. And benzos are definitely on my list of potential exposures here because they cause altered mental status and sedation. Cannabis use is common in this age group, but this isn't a marijuana overdose, and it isn't a common toxin in suicidal ingestions anyway. Amphetamines such as Adderall are easy to find in school. Cocaine and methamphetamine are possible. Is this a sympathomimetic overdose? Again, no. If you remember, sympathomimetics cause high blood pressure, high heart rate, and sweatiness. You return to your desk to check on her results. The labs come back with an abnormal drug level. Remember, we sent an aspirin level and an acetaminophen level. Which one do you think is elevated? A, aspirin, or B, acetaminophen? The answer is B, the acetaminophen level. How do we know it's not an aspirin overdose? Well, her vital signs. Aspirin overdoses cause acidosis. To compensate, the respiratory rate increases as a way of eliminating the acids. See the episode on therapeutic misadventures for more. In adults, it's almost impossible to have a significant acute aspirin overdose with normal vital signs. Acetaminophen, brand name Tylenol in the US, and called paracetamol outside of the US, brand name sometimes Panadol, is one of the most common overdoses we treat. 60 million people per week take acetaminophen in the US alone. Overdoses, both intentional and unintentional, account for 56,000 ED visits in the US, 2,600 hospitalizations, and 500 deaths per year in the US alone. It's the number one cause of liver transplants here and the number 2 cause of liver transplants worldwide. This is the paradox of this drug. Acetaminophen is one of the safest drugs we have in therapeutic doses. In overdose, it's one of the most dangerous. Our patient's acetaminophen level is 300 micrograms per deciliter, and her liver function tests, the ALT and the AST, are extremely elevated at 10,000. Question number 3. What is the best treatment at this time? A, N-acetylcysteine or NAC, B, a barbiturate coma, or C, a liver transplant? The answer is A. N-acetylcysteine is the antidote for acetaminophen toxicity. Our patient needs it immediately. She may need a liver transplant, but that's not the first step. And barbiturate comas can be used to treat cerebral edema or brain swelling. More on this in a bit. Let's talk first about acetaminophen overdoses, then come back around to the antidote. As I said, APAP. Why do we call it APAP in medicine? Because of its chemical name, N-acetyl paraminophenol, is an extremely common overdose in the US and Europe. Acetaminophen is classified as an antipyretic and analgesic, meaning it treats fever and pain. It has minimal anti-inflammatory effects, and surprisingly, exactly how it works is not clear. Generally, it inhibits cyclooxygenase and prostaglandins, part of the pathways mediating pain and fever. In therapeutic doses, APAP has very little toxicity. At higher doses, however, it overwhelms the liver's capacity to safely metabolize the drug. These secondary elimination pathways result in toxic metabolites, including one called napkin. NAPK is hepatotoxic, damaging and killing liver cells. Patients with low glutathione stores, like chronic alcohol users, malnourished patients, and those with AIDS, are at higher risk of toxicity because they have reduced capacity for safe metabolism. Acetaminophen toxicity develops over 4 stages. Patients in stage 1 may have nausea and vomiting, maybe some abdominal pain, or they may be completely asymptomatic. Stage 2 occurs within the first 24 hours and is characterized by liver injury with rising liver function tests. Stage 3 is hepatic failure, and this occurs within 72 to 96 hours after overdose typically. And patients can also have renal failure, bleeding, low blood pressure, acidosis, and encephalopathy or an altered mental status. Interestingly, bleeding is common with other causes of hepatic failure because the liver makes the blood clotting factors. However, it's relatively rare in APAP toxicity. Death occurs in this stage between days 3 and 5. Patients die from ARDS or acute respiratory distress syndrome, sepsis, and most commonly they die from cerebral edema or brain swelling. Back to this in a minute. So the bad news, our patient is in stage 3. Stage 4 is recovery. One of the amazing things about APAP toxicity, if you survive, your liver completely regenerates and returns to normal with no residual damage. The antidote, N-acetylcysteine or NAC for short, protects the liver in several ways. It limits NAPK formation and helps to detoxify it. It also has a general protective effect in liver failure, the mechanism of which is well established but not well understood. In fact, we use NAC for other types of liver failure, despite a lack of proven benefit in the hopes it'll work for things like, for example, mushroom poisoning. NAC is very safe with few side effects. The main adverse effect is anaphylactoid reactions, which is histamine release causing rash and itching and fever. It looks like, but it isn't a true allergic reaction. The symptoms resolve with slowing or briefly stopping the infusion. You can buy oral NAC over the counter from supplement stores. And this brings us to the route of administration. It can be given orally or IV, and they both work equally well. Originally, it was only available by mouth, and the protocol was you needed a dose every 4 hours for 72 hours. NAC stinks like rotten eggs, so just imagine trying to get somebody who's already suicidal to drink a foul-smelling concoction every 4 hours for 3 days. These days, we mostly use the IV preparation. If you start NAC within 8 hours of the overdose, it's essentially 100% effective. It's pretty amazing. The mortality after an acetaminophen overdose is only 0.5% thanks to NAC and to liver transplants. But our patient is critically ill, and I'm worried she's about to become one of the few people who do die after an acetaminophen overdose. Did we start the NAC in time? Well, let's talk more about her case specifically. She has a high acetaminophen level and high liver function tests both at the same time. Additionally, the parents said the symptoms started yesterday, meaning this is a delayed presentation. None of these things are good prognosticators. One of the best tools we have in toxicology is the Rumack-Matthew nomogram, used to determine if an APAP level is toxic. It's a graph where you plot the level against the time of ingestion. If the level's above the line, you treat with NAC. If it's below the line, you don't have to worry about significant liver damage, and no treatment is necessary. I'm told Barry Rumack and Henry Matthew drew the first graph on a cocktail napkin. The original line they drew started at an APAP level of 200 micrograms per deciliter at 4 hours. However, the FDA wanted to introduce a margin of safety, so it was lowered by 25%, and in the US, we mostly use a cutoff of 150 micrograms per deciliter at 4 hours as the treatment line. Different countries do have different protocols. Some use the 200 line, others lowered it even further to 100 micrograms per deciliter. Given that our patient has a level of 300 at least 12 hours after ingestion, I'm very worried she took a massive overdose. She didn't arrive at the hospital within the 8-hour window, but NAC is still critical. Studies have shown NAC reduces the need for vasopressors, medicines for dangerously low blood pressure, and it reduces cerebral edema. You order an infusion of NAC and go back into the room to talk to the parents. Mom's shaking the patient, who is not responding at all. This is not good. You intubate the patient and put her on a ventilator. What happened? Most likely cerebral edema. You order a CT scan on the way up to the ICU, and the CT results are just as we feared. Instead of a normal brain with ridges and indentations, sulci and gyri, her brain looks smooth. It's basically swollen. The radiologist reports signs of brain herniation. The inside of your skull is a fixed space, so if your brain swells too much, Then the brain starts to become squished with loss of the normal spaces inside, and this is called herniation. The ICU team consults neurosurgery for recommendations to try to reduce the swelling. Unfortunately, many patients die of cerebral edema after Tylenol overdose despite treatment. Barbiturate coma, rarely used these days, is an option to try to reduce intracranial pressure. Our patient's life is hanging in the balance. What else can we do? Well, there are some new treatments emerging for massive APAP overdoses. The data is pretty limited, so let's discuss the risks and the benefits. First, there's some evidence that higher than standard doses of NAC may be helpful. The downside here, basically none, so let's increase the dose of the infusion. Second, and interestingly, a different antidote may be useful, the antidote for toxic alcohol poisoning. Remember what it is? Famepizole has shown some promise. Again, famepizole has essentially no side effects, so let's start giving it as well. And third, dialysis removes some APAP. Dialysis definitely has significant side effects. You need a large catheter, there's a risk of infection. It is not a benign procedure. However, the patient is dying, so the benefits outweigh the risks here clearly. The specific indications for these therapies are massive APAP overdose. This is variously defined as levels from 300 up to 900, including cerebral edema, hepatic failure. But at this point, there's no question our patient took a massive APAP overdose. The intensivist calls the transplant team to determine if she's a candidate. Question number 4. Patients with acetaminophen overdose do better after transplant than patients with other causes of liver failure. A, true. B, false. The answer is B, false. Transplantation after APAP overdose is a very tricky issue. In fact, liver transplant in general is a tricky issue. We don't have enough organs, so as a result, there's a narrow window where the patient is sick enough to qualify for the transplant but not too sick to survive the operation itself. Overdose patients are much healthier than other patients with liver failure, for example, those with liver failure from cirrhosis due to alcohol or hepatitis. The overdose patients are often younger in age and with fewer comorbidities, but despite this, they often have worse outcomes after transplant. Why? Because most patients undergoing transplant have undergone also psychiatric screening to qualify. Patients with significant barriers, for example, concern about being able to take rejection medicine regularly, are not candidates for transplant. But patients with overdoses aren't screened prior, and you don't need me to tell you that patients with suicidal ideation aren't in top psychiatric shape. Some are not happy to wake up alive, with their health now much worse than it was before they overdosed, committed to a lifetime of daily medicine use. And the medicines themselves have potentially serious side effects. The facts: about 12% of post-transplant patients attempt suicide again or intentionally stop taking their anti-rejection medicines, causing life-threatening consequences. As hard as it is to believe, patients with liver transplants have overdosed on acetaminophen again. So these facts have been used to justify not transplanting. However, despite this, transplants are life-saving. Sick patients who weren't transplanted after acetaminophen overdoses have survival rates between 25 to 40%. With transplants, survival rates are 69 to 83% immediately after surgery, and in 3 to 5 years remain higher at 50 to 66%. Now, not all overdoses are intentional. Accidental overdoses are also common. Unintentional overdoses happen when patients are confused by doses, timing, or ingredients in medicines they're taking. For example, Percocet and Vicodin are both opioid and acetaminophen combination pills. Patients who take extra doses for pain or who are misusing the drugs often don't know they might be taking too much APAP. This became a big issue during the opioid crisis, as many misusers of opioids developed acetaminophen toxicity, liver failure, and needed liver transplants. To address it, in 2014, the FDA mandated combination products can contain a maximum of 325 milligrams of APAP per pill. Question number 5, true or false? Acetaminophen is contraindicated after a liver transplant or in patients with liver cirrhosis. A, true. B, false. The answer is actually false. Patients often tell me they've been told not to take acetaminophen, but it's safe for anyone to take up to a maximum dose of 2 to 3 grams per day. Acetaminophen was rarely used in the U.S. until the 1980s when the association between aspirin and Reye syndrome in children was discovered. So acetaminophen became a safer alternative. at least until September 1982, when some of you may remember the very tragic Tylenol murders in Chicago, when 7 people died after taking Tylenol contaminated with cyanide. Surprisingly, the murders remain unsolved to this day. Johnson & Johnson introduced tamper-proof packaging to prevent poisoning, which soon became standard for all over-the-counter medicines. Management of acetaminophen overdoses is often much more nuanced and much more complicated than plotting points on the nomogram. For example, the time of ingestion is often unknown, rendering the nomogram useless. Extended release preparations can't be plotted on the nomogram either. Acetaminophen toxicity is a huge topic covered in great detail during toxicology fellowships, and the finer points of management are debated even amongst the most famous toxicologists. In the interest of time here, I focused on a serious but classic presentation. If you're concerned you've taken too much, have a patient who's taken too much, or otherwise need help, the best approach is to call the Poison Center at 1-800-222-1222 or consult your local toxicologist for help. Back to our patient. She's listed for transplant, rising higher on the list as she continues to worsen despite aggressive management. Her liver fails, her brain swelling doesn't respond to any neurosurgical recommendations, but no liver matches are found. The ICU team does what they can to prepare the family for the likelihood she won't survive the overdose. After 2 more days, against the odds, she slowly begins to improve. The brain swelling resolves and she wakes up. Her family is overjoyed she's alive, and hopefully with some psychiatric treatment, the patient will feel the same. This is a fictional case, as are all our cases, to protect the innocent, but it is based on real poisonings. One last interesting fact before we go. What if your dog or cat gets a fever? Can you treat them with acetaminophen? Interestingly, no. Tylenol is extremely lethal to cats as they don't have the enzyme to metabolize it. It's slightly less, but still very significantly toxic in dogs. This brings us to the last question in today's podcast. Acetaminophen has been used as a lethal bait for which animal? A. Rats, B. Snakes, C. Toads, D. Africanized honeybees. Follow the Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Finally, thanks for your attention. I hope you enjoyed listening as much as I enjoyed making the podcast. It helps if you subscribe, leave reviews, and/or tell your friends. All the episodes are available on our website, pickpoison.com, Apple, Spotify, or any other location where podcasts are available. Transcripts are available on the website. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you, and until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.